Good evening, ladies and gentlemen, and welcome to the Royal Photographic Society's Combined Royal Colleges Medal Award for 2020 corresponding lecture. I'll introduce our speaker tonight in a moment, but first a few words about the award. The Combined Royal Colleges Medal was originally established by the Royal Photographic Society back in 1958 in collaboration with the Royal College of Physicians in London, the Royal College of Surgeons of England, and the Royal College of Obstetricians and Gynecologists.
There you go, I'll turn mine off now.
And since 2015, they've been joined by the Royal College of Psychiatrists and Royal College of Ophthalmologists. So at the moment we have in excess of 4 Royal Colleges for the award. This prestigious medal is awarded for an outstanding contribution to advancement and or application to medical imaging in the wider field of medical imaging. And the recipient of the award is required to give a lecture the year after receiving the actual award itself at one of the Royal Colleges normally. But unfortunately, thanks to COVID, we've had to revert to here at the RPS house in Bristol. Hopefully in due course, when things get back to normal, we can have face-to-face meetings at one of the Royal Colleges, and that'd be wonderful to get around to. Anyone who's a member of the Society or even not a member of the Society can nominate any person, whether they also be a member or a non-member of the Society, and also of any nationality. So tonight's award is actually truly international. And the closing date for the next nominations, whilst not fully set yet, is looking to be February of next year. So to nominate somebody, please visit the www.rps.org/awards, where you can complete a nomination form. So first and foremost, I would like to congratulate Pankaj Chandak for being awarded the Combined Royal Colleges Medal and for 2020. And congratulations again on behalf of all the awards committee members as well, who would like to forward their best wishes for your future endeavours as well. So further to that, I'd like now to introduce Pankaj Chandak and give a brief introduction as to his career so far. So Pankaj is a trainee in transplant surgery within the London Deanery of Guy's, Evelina and Great Ormond Street hospitals, and a postdoctoral research fellow in the Faculty of Life Sciences at King's College London. His scientific interests include complex paediatric transplantation, innovation, as well as translational research into organ manipulation and regeneration, as well as public engagement in science. Pankaj interdisciplinary research has led to the first reported clinical integration of 3D printing technology into complex transplants in children. The original models used in the first cases are permanent exhibition in the Medical Welcome Galleries in London Science Museum. Pankaj has been awarded the Royal Society of Medicine Norman Tanner Medal, the Royal College of Surgeons Cutler's Clark Medal, and the Royal College of Surgeons of England Joseph Lister Prize and Medal. In addition, he delivered the British Science Association Charles Darwin Award lecture at the British Science Festival, and is also a recipient of the Royal College of Surgeons Arnott Lecture and medal delivered on living donor transplantation. In 2017, he was awarded the International Paediatric Transplant Association's inaugural Young Scholar Award, an international award for trainees for excellence in the field of paediatric transplantation, and was recipient of the UK Health Tech Pioneer of the Year Award in 2018. Pankaj has been invited speaker to the Royal Society, the Royal Institution, the International Transplant Network, the Women's Institute, and the Federation of Clinical Immunology Societies. Additionally, his appearance in the Netflix series, The Crown, where he played the surgeon operating on King George VI, was a first for television where real-life surgeons act in film, and he remains directing medical advisor to the series. He has made appearances in the BBC World Service and the BBC Children and Need Appeal show, where his choir of the transplanted children called Harmonies of Hope have performed. Pankaj was elected a Fellow of the Royal Asiatic Society and a Fellow of the Linnean Society for his contributions to the biological sciences through his 3D printing work for anatomically complex transplants in children. So, without much further ado, I'd like to bring forward Pankaj. And towards the end of the lecture, we will field any questions, either Zoom or within the actual auditorium itself. But meanwhile, I would like to bring forward Pankaj and introduce tonight's lecture.
Well, thank you very much for that very kind introduction, Mr. Hawkins, and I thank the Royal Photographic Society for this award that recognises our work of 3D printing for paediatric transplantation. It's really an honour, and it's really humbling to know that previous recipients of this award have included the inventor of the capsule endoscopy and imaging of the eye, as well as MRI imaging of the fetal heart. So it's quite extraordinary the work that's gone into imaging sciences in the last few years. But I'm here to take you through a journey of 3D printing technologies and how it's used in transplantation and also its wider field. But before I do that, I must really pay tribute to the founding father of 3D printing technologies, Charles Hull. Now, Charles Hull was in fact the recipient of the 2020 Royal Photographic Society Progress Medal, and it was Charles Hull who originally developed this concept in the 1980s of 3D printing, which essentially is a process of trying to create a three-dimensional object from digital data by successive layering of materials in an additive-like fashion. So it's called an additive manufacturing technology under computer control. And he was actually investigating how to harden tablecloths with UV light at the time. And since the 80s, 3D printing has been widely used in industrial applications. But its emergence in the medical world has mainly centered around its use in congenital cardiac surgery, maxillofacial surgery, orthopedic surgery, and it's been shown to reduce surgical times and improve operative accuracy. So it's been used not just for surgical planning, but with respect to orthopedics, it's been used for implants and creation of prosthesis. So it has been used in the medical field, but in terms of transplantation, it's fairly new. So before we come to its use in transplants, I just want to take you back to the concept of organ transplantation, which has been around really since the 1400s, as you can see from this beautiful painting here of Saint Cosmos and Saint Damien. So these are two saints, and they're replacing the leg of this man with the leg of another man, and it's the first sort of concept of replacing a diseased human body part. And then you can see from this a picture of this surgeon scientist, John Hunter, a very famous surgeon in the 1730s, who actually carried out experiments to demonstrate the first use, the first description, if you like, of xenotransplantation, which is transplantation across two different types of species. What he did was he took human tooth and embedded it into the head of a hen, and he dissected this specimen, which is at the Royal College of Surgeons Interior Museum, and you can see that the tooth is embedded into the head of the hen with blood vessels that are injected into it. So it's the first example, if you like, of xenotransplantation. He then went on to do tooth-to-tooth transplants between many different people, gave them syphilis, many died that way. But actually, his heart's in the right place. But there we go. Since then, we can transplant almost any solid organ, including obviously the heart. 2017 marked the 50th anniversary of the first human heart transplant by Christian Barnard. Obviously the kidneys, and in 2018, even uterus transplants. So solid organ transplantation, although it's a relatively young surgical specialty, is progressing very rapidly. And there are still barriers and challenges. And one of those is actually in children. So how can we make transplantation safer for children? So here's a lovely photograph of Lucy Boucher and her father, Chris. Lucy was only 10 kilograms when she presented to us in need of a kidney transplant, and Chris was going to be her living donor. He was going to donate his kidney to her. So I'll come back to them a bit later on. But essentially, I was interested in seeing how we can make transplantation safer for children like Lucy. So here's a graph from NHSBT, which essentially shows that the number of children on the transplant waiting list is increasing over the last 3 years. And you can see that here, it's going up. So there is a real need to transplant children quickly and timely. And the reason for this is because children generally don't do too well on dialysis, especially small children. So here's, again, data from the North America clinics, and it shows basically children who are small, so this black line here, have poorer outcomes on dialysis with longer duration compared to slightly older children. Therefore, it's a real need to transplant these children quickly, preemptively, ideally before they're on dialysis, and that too with a living donor. And so why is transplantation generally better than a life on dialysis? Well, not only does it offer a survival benefit, but actually it's superior to dialysis with respect to all these other factors, such as growth, cognitive development of the child, psychology, and of course, quality of life. But there are challenges. What are those challenges? Well, essentially, there are two big challenges that we face. The first is size discrepancy in the adult donor kidney placed into a small child. And by small, I mean less than 20 kilograms. Now, you may be wondering why we place adult organs into babies and children. And the reason is because if we implant small kidneys into children, which can be done, and it is done, but there's a higher risk of those kidneys clotting off and thrombosing, and a high risk of those kidneys being damaged due to something called hyperfiltration injury. So ideally, we would like adult kidneys into children. So that's the first problem, size discrepancy. And just on that point, actually, almost 19% of adult kidneys are sometimes discarded due to size mismatch between the recipient, the child, the recipient, and the donor kidney. That's data from the United States. So that's an important source of organs that we must tap into. The other challenge is some of these children have quite complex abnormalities of their blood vessels. And normally, in a small child, we would implant the kidneys onto the aorta and the inferior vena cava of the child. So this is a child less than 20 kilograms. So make a midline cut, expose these two blood vessels, and we stitch the donor kidney onto these blood vessels. The child is slightly older or larger than 20 kilograms, we would implant the organ like we would do in an adult, and that is onto the iliac vessels through a cut on the side here into the pelvis. But often these children, as I say, can have complex abnormalities of their blood vessels. And here's one example of that. So this is a 3D reconstruction of a 6-year-old child who underwent an abdominal aortic aneurysm repair at the age of 3, which required a plastic graft, a PTFE graft to be placed right high up on the aorta, supraciliac, all the way down towards the aortic bifurcation. The aorta divides into two, into the common iliacs. And then this also required reimplantation of this child's visceral blood vessels, which are the vessels that supply the organs, into the graft itself. So you can see quite a complex meshwork of blood vessels in and around the aortic graft. So this child presented to us for transplantation. So the question is, where can we actually find a suitable piece of native blood vessel for us to actually go ahead with the transplant? So that's the kind of dilemma that we're faced with. And indeed, these blood vessels can be occluded. They can be absent. So you can just be born with blood vessels that just simply don't exist, or they can be narrowed, such as mid-aortic syndrome. There's an image of that. So this is a child whose aorta just completely disappears. So that's mid-aortic syndrome. Or they can be twisted. They can have quite a complex sort of trouser leg twisting sort of configuration. And I've got an example of that to show you later on. Here's an example of a child's that's got absolutely no IVC, and they've got lots of dense collateral blood vessels forming as a result of that. And of course, these children present to us for a transplant. So one approach that we thought of was trying to classify these lesions. Therefore, we can stratify approaches and then use this to help perhaps build a registry of complex cases that may help guide management. For example, we have here the aorta and the IVC. So if the entire abdominal aorta is absent, as is the case with the IVC, this could be classified as an A4-V4 case. And of course, if they're entirely present, it will be an A1-V1. And then the various varieties in between. So this might be useful to stratify cases and to help build a registry database. But how do we plan surgery in these children at the moment? Well, indeed, and the question really is, what are the current limitations of the imaging available that we use to help determine feasibility of implantation? Well, all our cases at the moment are discussed in a big multidisciplinary team involving the surgical team, the anesthetic team, the radiology team, the intensivists, and sometimes even the family, and where we view the anatomy. So essentially it's a three-dimensional structure which we view on a two-dimensional computer screen. But this demands a radiologist then to interpret that anatomy and convey that to the multidisciplinary team. And of course, you can't interact with those images in a tactile where you can't appreciate perhaps the complex anatomical arrangements and configurations, and you cannot simulate procedures on a 2D computer screen. So what happens when we have cases where we can't quite determine the feasibility of implantation? We often have to open the child up first before we take the donor kidney out to perform surgical exploration of the child, to view the anatomy, and then to determine feasibility. And once we've determined feasibility, we then proceed with the donor operation, who basically in the next operating theatre, or in our case, it will be at Guy's, and the child will be at Great Ormond or Evelina. And then the donor surgeon is now under a little bit of pressure to take the kidney out fairly swiftly, because the child is under anesthesia and may already be 3 hours into the operation before we've even begun the actual transplant itself. So so that's occasionally what happens, and as you can imagine, it can be quite a stressful situation for both implantation and retrieval teams. So the question really arose: can we predict feasibility in the presence of these complexities using 3D printing of the adult donor kidney and the child's abdomen? So that was the question that I had to try and address some of those issues. And the approach we adopted was essentially a twofold approach. The first is a proof of concept approach. Can we actually 3D print the human kidney, and can we actually 3D print the baby's abdomen? So we decided to test this. We'd do a retrospective case. And the second was then translation of that into clinical practice. So can we then assess the technology prospectively in complex living donor pediatric transplants where the feasibility is uncertain? So this shows our workflow scheme, essentially. And it's a fairly linear process, which is well documented in 3D printing literature. Essentially, we extract the relevant anatomical data from CT scans and MR scans, and then we use Mimic software to generate this computer-aided design. So here's a kidney that we've generated using the extraction of the anatomical data, and then we use UV light essentially to mold liquid plastic resin to produce these morphologically specific models. And we use a variety of different materials here. This is the software that we use, and here's our 3D printer here, which is housed in the Department of Medical Physics at St. Thomas's. It's a state-of-the-art 3D printer, and different specialities within the hospital use them, including maxillofacial surgery and orthopedics, and it's an Object Connect 1 printer. So here's a example of segmentation occurring of a pediatric congenital heart. So you can see here how we extract the anatomical data from the conventional imaging, and this generates a design of the heart. You can see there, and I thank Nick Byrne for this, my colleague who works in medical physics. And then you can see the printer head here laying down liquid plastic resin, which is then molded under UV light to create a specific, patient-specific, I should say, morphological object. And that process can take up to about 12 hours or so. The actual time-consuming bit is actually in the segmentation, where we have to extract the anatomical data, which then has to be approved by radiologists. So that's where the actual work in terms of hours is placed. So here's our proof of concept case. It was the case I mentioned earlier about the child who had the aortic aneurysm repaired, and that child was transplanted without the use of 3D printing. But what we did was we retrospectively printed her models, and this again shows our patient-specific 3D printing workflow scheme. So proceeding from left to right, There are various steps in this process. The first is image segmentation, as we've already discussed, to extract the relevant anatomical geometries from routinely acquired medical images. We then create this computer-aided design, which is then adapted and prepared, and then the geometry is sort of adapted, if you like, for fabrication. And then the final step is 3D printing, which is done by our printer. And of course, we then have surgical manipulation, where the surgical team use the models to aid preoperative understanding of anatomical complexity. And what we showed here was that there was geometrical correlation between the model and the CT scans and MR scans. And we showed this to 5 independent surgeons who confirmed its value as a preoperative planning tool that would have been very useful if they had prior to surgery. So this child, as I said, was operated without the use of 3D printing, and initially this child was explored on table, and a couple of hours into the operation, we found a small piece of aorta just beneath the graft in which we transplanted onto. So the next step was to try and validate this. So is the printer reproducing the data file that we're putting in? So we wanted to determine geometric consistency, if you like, between the STL segmented design files that we're putting into the printer and then the model itself. So we CT scanned the models and then produced an STL segmented design file of that model and compared it, if you like, to the original file that was put in. So here's an example of that on this slide. On the left-hand side here, this file with the blue center line is the STL file of the model after it underwent a CT scan, and we compare that to the original STL file that was put into the 3D printer itself. And then we drew a center line down the vascular tree and measured from the center line various points of diameter along the entire vascular tree, up to the outer margins of the actual vessels, and compared them to each other. And what we found essentially was that the diameter of the printed model is smaller than the original input file by about 0.1 millimeter, which of course compares favorably within the limits of surgical precision. So essentially, the printer is capturing exactly what we're trying to put in. So we then decided to translate this into 3 unique scenarios in pediatric kidney transplantation where feasibility of transplantation was uncertain. The first is in the small pediatric recipient. The second is a child that required a 2-stage procedure involving removal of the native kidneys first, followed by a living donor transplantation. And the third is a small pediatric recipient with complex vascular abnormalities. So let's just take each of these in turn. So here's the small pediatric recipient. So this is actually the case of Lucy and Chris. So as I said, Lucy was only 10 kilograms when she presented to us for a kidney transplant, and she'd had lots of previous abdominal surgery. So we're worried about scarring inside the abdomen and worried how this may distort the anatomy. And of course, Chris was donating his right kidney to her. So we followed our workflow stream, just like I described before. And here's a photograph showing the size discrepancy between Chris's right kidney and Lucy's entire abdomen. So here's the liver. Here are Lucy's native kidneys. These are the lateral abdominal walls. And this is the pelvis, which is printed in a very hard material compared to the rest of the softer materials here. So the printer has the ability to capture some of those properties, just like it would do in the body itself. I mean, the soft tissues are not exactly like human tissue elastic properties, but there's lots of work going on at the moment to try and do that. But certainly the pelvis was. So that's a hard bony structure there. So essentially, we've got to try and implant this kidney into this space here. There's the IVC, and there's the aorta that you can see here. So I've got a short video now just to show Professor Mahmood manipulating this model before the surgery to look at ways in which we can implant it. So, you can see here the donor kidney here, and what we're doing now is looking to see the best lie of the kidney within the abdomen itself, whether we need to mobilize the liver slightly higher up to create space, and critically, the model gives us depth perception, which you cannot quite appreciate on a 2-dimensional computer screen. And indeed, whether we need to take out Lucy's right native kidney, which is the size of a small walnut. There you can see that. The model told us perhaps we didn't need to do that, but of course, that's a decision that you take intraoperatively. It told us about the best approach to the blood vessels for the anastomosis, the suturing of the donor vessels onto Lucy's recipient vessels as well, and the line of the incision. So that model was used for planning her transplant, and you can see Professor Mahmood there just pointing to the vessels there, and the line of the kidney is exactly what happened in the operating theatre here. So this was the first case that we did prospectively using 3D printing technology. So the second application was this two-stage procedure. Again, a 12-kilogram child who had bilateral renal artery aneurysms and also an aneurysm from the inferior mesenteric artery, which is a branch of the aorta. So you can see here the 3D model, which shows dysplastic, very abnormal-looking kidneys and associated with multiple hilar aneurysmal blood vessels. And then what we did was that we used the model to plan the posterior approach to taking both of these kidneys out. So this is a posterior retroperitoneal approach done through laparoscopic surgery. And you can see a clear representation of the hilar vessels for planned transection, which you can see the double lines here. And then the operative photograph here is a laparoscopic view of those blood vessels, demonstrating vascular configuration consistent with what we found on the model. We carried out those transection of those vessels as planned. So once those kidneys were removed, the child then had a period of rest, and about a month later, we then proceeded with the living donor transplant. So this is a kidney from his parent who was donating the left kidney, and then we had to deal with the aneurysm coming off the aorta, which is, you can just see here. So this again shows the size discrepancy, if you like, between the small abdomen of the child and the donor kidney, and it also shows our planned approaches for the anastomosis, the joining of the blood vessels onto the baby's IVC and aorta. And the model told us that we could actually resect the aneurysm at the level of its neck safely. So that was a useful model for a two-stage procedure in a child. And then the last example was a child with complex vascular abnormalities. So if you remember earlier, I mentioned that sometimes these vessels can be completely twisted. So again, we had a 14-kilogram child who presented for transplantation. And the problem with this child in terms of the aorta was that it split very high up. It's a high bifurcation, and there was complete twisting of the branches coming down towards the leg. And so this child was presented at the multidisciplinary team. Half the surgeons thought this was a feasible transplant, and the other half thought it wasn't. So we 3D printed it, took it back to the multidisciplinary team, and 100% of the surgeons then felt that this procedure could proceed with confidence. And that's the planned simulation of the kidney, the living donor kidney, and the anastomosis windows that you can see on that model. And we took the model into the operating room, and you can see those. This triangle here really shows where we're going to suture the blood vessels onto, and intraoperatively the anatomy correlated geometrically to the model, and the anastomosis windows are shown. Was not entirely possible to determine with full confidence prior to 3D printing. So you can see there's the IVC, there's the aorta. So that child went on to have a successful transplant. This is a 15-year-old male who had complete occlusion of the inferior vena cava, and you can see quite complex, dense collaterals forming on either side. Again, we 3D printed the model based on the conventional imaging, and we planned to attach the renal vein onto one of the collaterals on the left-hand side, just up here. So again, that was used as a preoperative planning tool. So this slide really shows our first few cases that we did in children ranging from 18 kilograms to 47 kilograms. We've done over maybe 30 or 40 cases now, but critically in our first few cases, all these children had some structural complexity that rendered transplantation feasibility uncertain, especially after conventional review of the medical imaging. So whether it's a small abdomen, whether it's a complexity with the blood vessels, and each illustrates the value of this technique in a different type of surgical challenge. And we gave the model scores out of 1 to 5, 5 being excellent, 1 being poor, and it shows here the clinical outcomes. Our proof of concept case, sadly, died from an unrelated cause, but all the other children had a successful outcome. More recently, we have developed another related application of 3D printing, and this is to facilitate complex repair of renal artery aneurysms in children with renovascular disease. So often these children may have high blood pressure, which requires lots of medication to control, and they have complex anatomical aneurysms. So you can see this is a 13-year-old female who had a complex arrangement of the renal artery aneurysm, which was extending actually into the kidney. And she was discussed again in the multidisciplinary team, and the plan before printing was to consider auto-transplantation. So this involved repairing the aneurysm and removing the kidney from the original position and then auto-transplanting it down into the pelvis. And of course, that's a prolonged procedure, and that can cause some morbidity. But when we 3D printed the models, took them back to the multidisciplinary team, the approach became slightly different. We thought perhaps we could still repair the aneurysm, but with the kidney in the same position. So what we do is that we cool the kidney down with ice, repair the aneurysm without the need for auto-transplantation. And of course, this is beneficial to the child in many ways because you don't have to, it's a shorter operation, but you don't have the problems of warm ischemia where you have to then reattach the blood vessels onto the recipient blood vessels, which can obviously compromise graft function. So, so that was one interesting case where we used 3D printing for this particular reason. Now, another use of 3D printing in our unit was for robotic transplantation. Now, robotic surgery has obviously been around for a while. It's been used in various surgical specialties such as urology, cardiothoracics. And essentially, this is where an electromechanical device is capable of performing a variety of tasks on command or being programmed in advance. And we use a Da Vinci machine. So here are a couple of surgeons sitting at the consoles, not sterile, using a Da Vinci machine to operate on a patient here with a sterile person just here. So this is the standard Da Vinci robot, and this is from Intuitive Surgical. So back in 2016, we performed the UK's first robotic kidney transplant using the Da Vinci machine. This was led by Professor Mahmood, Nikos Gisaris, and also Professor Pranjal Modi from India, who came over to mentor us for this program, who's done almost 500 robotic kidney transplants, the largest series in the world. All the couple of patients that we operated on essentially went home within 4 days of the transplant, which was absolutely amazing. So there's Professor Mahmood, they're sitting at the console, and this is the operating team just here working away. So you may be wondering what the advantages are of robotic assisted surgery. Well, compared to say standard keyhole surgery and open surgery, well, it offers excellent vision and dexterity. It filters any hand tremors. We all have a natural hand tremor, so the robotic instruments filter that. It offers more degrees freedom of motion, if you like, compared to standard laparoscopic instruments, and of course to the human hand. And less fatigue compared to standing up for a long time during a long procedure. So it does have its advantages. So can we do it in children? Well, yes, we can. So Professor Modi from India has done probably more than 30 children now in the last few years robotically. And all these patients have had 100% patient and graft survival, and they often go home within a few days of transplantation. So we have yet to do a robotic kidney transplant in a child in the UK, but it's something that we're going to be working on. So the question then arises, how do we train surgeons in new techniques? How do we familiarize ourselves with these innovations, especially during our training years? And this is important. And this was a landmark paper just published recently by Professor Dasgupta's group from King's, which essentially compared simulation training of surgeons compared to conventional operating room training. This was an international multi-center randomized controlled trial. So the training surgeons were randomly allocated to these two arms. And what they essentially showed was that simulation-based training led to higher overall proficiency scores than conventional operating room training. And simulation actually improves performance in real operated settings, and of course can reduce surgical complications for complex procedures. So there is a role for simulation training. So how can we translate that now into training for robotics? Well, we can, and in fact, we've used 3D printing for this. So this work has been led by my colleague Yanis Lukopoulos, one of the consultant surgeons at Guy's, and our team. And what we've done here is create a hybrid model of simulation for training of junior surgeons. So we've got a 3D printer model, and we've also used real human blood vessels. And I'm going to show you now how this works. So there's a short video coming up now of the model itself. So here's a 3D printed kidney taken of a patient. This is the pelvis, you can see just here, and we've got gaps here in the actual blood vessels. And what we do is we're going to now put real human blood vessels in those gaps that we get from a deceased donor bank. And we assemble this, you can just see that there. So we're going to put real human blood vessels there. And we're then going to then place the entire rig under the robotic arms. So use each of those in place. And these are real human blood vessels from deceased donors that we've got stored. And then we practice the suturing. So ideally, we've got to do this stitching of these vessels in about 40 minutes, because the longer it takes, the worse the outcome is for the graft. So hence, this is a model that's using real human tissue, if you like, within the setting of a 3D printed model. And this is actually a real robotic case taking place. So you can see it's very realistic. And so the trainees can then practice this and try and get the suturing skills up to speed and doing it safely and accurately. So there's how we do it. And you can see here is the hybrid model. It's a very similar way in which we're doing it compared to the real thing. So that's a way in which we've used 3D printing with real human tissue. The next step was to try and validate this model as a simulation training model, if you like, for robotic kidney transplantation. This is work done by my colleague, Raf Uwechui, who's a research fellow and a transplant trainee who works with me. And he looked at comparing experts to novices within this model framework. And what he found essentially was that for all the different characteristics here, such as depth perception and bimanual dexterity, efficiency, and force sensitivity and robotic control, the experts do much better than the novices, as expected. And this really confirmed the validity of this simulation tool for robotic kidney transplant, vascular anastomosis, vascular stitching, and therefore it can be used as a training model to both acquire and maintain surgical skills. So the next step now is to go on further to look at this model with further validity studies. Another aspect in which we've used 3D printing is for robotic prostatectomy. Again, this is work we've done with Professor Das Gupta. We looked at 10 cases which had localized prostate cancer, and we found that the models provide good tactile feedback during robotic, in the planning of robotic prostatectomy. And we can appreciate the critical anatomy and preserving the neurovascular bundle, especially in relation to the sphincter. And we're hoping to plan a randomized controlled trial looking at that in the future. Now, there are other applications not directly related to the medicine as such of 3D printing. And in my experience, one of the greatest things that we tried to do in terms of helping the COVID cause was 3D print PPE. So Guy's and St Thomas's teamed up with iMaker, and we ended up doing lots of 3D printing of PPE. And here's a group of students from Brunel and King's working all hours, day and night, to make almost 800 to 1,000 visors a day and shipping them off to different hospitals around London. So that was a really fantastic way in which to use the technology. So what have we learned so far? So we've learned that essentially the 3D printing can help us appreciate anatomy. Well, it's fairly easy to understand and translate clinically because as surgeons we operate in layers, and it allows simulation to take place with informed planning. And importantly, you can develop a personalized consent process for the family. So you can take a model and go to a family and say, this is actually a real anatomical representation of your child's abdomen. And this is the kidney that we're going to be putting into this abdomen. So I find that that's a really crucial way in which we can establish rapport with the family in complex operations, because often we don't know it's very hard for us to quote a percentage risk when we're doing some of these operations because we're not doing enough of them. And so if you have a model and you can explain the surgery to the family in steps, I find that's much more useful than line drawings. And also you can develop an archived collection of training for future surgeons. And this is really important because often some of these cases that you see will be as a consultant or as a very senior trainee. But if you can show and discuss some of these cases very early on in training for surgeons, I think that's a very, very beneficial process. So where are we going to be in a few years' time? Well, we've spoken about 3D printing for surgical planning. The future also lies in 3D bioprinting, which is a completely different area of science. But for example, just to touch on this, here's a human liver, which has been completely decellularized. All the cells have been removed, and we're left with the skeleton of the liver, essentially. And then this can be repopulated with various stem cells. And the idea is that, if you can implant cells from the patient's own cells, if you like, into the scaffold, then this patient may not need immunosuppression. So you can actually generate organs specific to the patient's genetics. And of course, there's lots of possibilities of stem cells and various laboratories around the world using this science to try and explore those possibilities. The kidney is a very complex organ. It's a bit like the human eye. You've got over 32 different types of cells within the kidney working at different physiological levels to different physiological stimuli. And one of the problems with actually creating or regenerating organs like this actually is the vascular blood supply, trying to get the blood vessels in, and also making sure that they don't fragment with variations in blood pressure. So that's really the Achilles heel of organ regeneration, but it's very exciting, and I think it's definitely going to be happening in the next few years. So just to last closing slides, really. I mean, this is Lucy now handing her models over to Selina Hurley at the Science Museum. She's now almost 5 years old. She's doing fantastically well, and has become an ambassador, if you like, for transplantation. So it's really good to see her grow and really look after her kidney. And just to end with a couple of quotes, really, from two of my inspirational heroes. One is Joseph Lister, professor of surgery at King's, who always said that there is only one rule: put yourself in the patient's place. I think that's a very powerful aphorism, if you like, for any healthcare professional. I mean, we can do all this fantastic innovation, but at the end of the day, what's most important is putting yourself in the patient's place. And I think some of these photographs do illustrate that. This is Professor Modi, who I mentioned earlier in relation to robotic transplantation. These 3 children he transplanted in 24 hours using 3 organs from the same donor. So one child received a liver transplant, and the 2 other children received the left and right kidneys, which is absolutely extraordinary. And of course, this children from our choir Harmonies of Hope. And of course, to end with a quote from a scientist, Michael Faraday, who said, "But still try, for who knows what is possible." Indeed, a very powerful aphorism for any scientist to keep pushing those boundaries. And with that, I would like to really end by thanking various officers of the Royal Photographic Society, in particular, Professor Afzal Ansari, Chairman of the CRC Medical Committee, for all his kind help and mentorship throughout this process and in preparation for this lecture. I also would like to thank Joe McDonald, the awards manager, for unfailing enthusiasm, really, and kind help in facilitating this lecture and the award, and for her incredible efficiency, and Dr. Michael Pritchard and the team here, and the editorial team at the RPS Journal, and Matt also for the AV support he's been given to us, and also finally an opportunity to disseminate our work through this Lens Society. So with that, I'd like to thank you very much. And of course, this is not a single person event. This is a huge team behind this, including Professor Nizam Ahmed and Nick Casares and Nick Byrne, who part of the 3D core team over the last few years. And we'd like to also thank all the patients and families. Without this, none of wouldn't have really been possible. So with that, I'd like to thank you. And if there's time, I'd like to just leave you with a small clip from our choir, just to illustrate some of the wonderful stories that these children had. So let me just see if I can.
Anyone who's watched Children in Need knows that we love a good sing-song. Our massive children's choir has inspired us all year after year. It's always been one of my favourite moments of the night. I'd like you to meet some children who have faced difficult times and the surgeon who knew that music could help them.
My kidney is called Kidney Junior. They transplanted it to me when I was 2 years old.
My name means faith. My kidney's name means hope. I got her when I was 4. She's very important to me.
My name is Abbas and I'm 9 years old. I had a kidney transplant 5 years ago because my kidney stopped working. I don't have a name for my kidney.
Can you all hear us okay? Yeah? Amazing, cool.
My name is Pankaj Chandak. I'm a specialist registrar in transplant surgery. A transplant is a big ordeal for the child to go through and the family to go through.
Hi, Iman.
I've had 14 operations.
Probably 5 or 10. I have had 50 operations.
Hi, Alex. Lovely to see you all.
I love singing.
I love singing. I love singing.
So, here we go.
The Harmonies of Hope Choir gives children who've had kidney transplants the chance to come together through music.
Some of the children have been through really, really difficult times. Unless you've been through it, you just don't know. So the choir is a way in which they could all have a united voice.
Despite the pandemic, the choir are still going strong, helping children enjoy the amazing things that music can do.
When I sing with them, I don't feel different. It makes me feel accepted.
It's not just me that's had a kidney, it's everyone else. So I'm happy.
When we're all together, it feels like amazing.
Well, Pankaj, what can I say? That's quite an amazing lecture, to say the least. Beg your pardon, I'm losing my voice here. And certainly towards the end, I was welling up just listening to those children. Sorry. Quite amazing to see where the technology has progressed over the years. Certainly, I know 3D printing of old, and it was actually quite poor quality. And I was actually amazed to see in one of your slides the accuracy you're now getting from MRI, CTs, and the combined technology of those, the 3D printing down to the 95 percentile was actually a level that I hadn't foreseen actually being possible.
Yes.
Where do you see that going in the future? Do you think it's going to become even more accurate? Do you think it's going to be?
Yeah, I mean, I think the technology is always improving. I think it's going to get more accurate with the great influx now of AI and algorithms. We can improve our segmentation process. We can improve the accuracy of trying to capture the anatomical details and through those different algorithms. And there's lots of work going on at the moment. King's looking at that. Yeah, I think it's a step-by-step process, and I think that one of the important things would be to try and reproduce, I say that the tensile property of human tissues in the model that can be captured. That will be a real advance, I think.
That's incredible. And when it comes to bioprinting and organoids, I know that's a technology in its infancy at the moment, and obviously we've been looking at transplanting animal organs into humans over the years. Do you see that as the way forward, especially with kidney transplants?
Yes, absolutely. I mean, I think there's a lot of work going on now trying to look at organoids and trying to look at organ regeneration. I think, again, the ultimate thing we try and create a human organ in its entirety, a solid organ, upscaling that from organoids. I think that's the key step, taking it from the lab to the bench, well, from the bench to the clinical side, but trying to upscale it. I think that's going to be the biggest challenge, really. But if we can regenerate failing organs, that would be also huge bonus, really. But yeah, and of course, there's lots of reports now coming out looking at xenotransplantation, and of course, using animal organs as well. I think that's a completely fantastic area of science. And if we can use that as an additional source of organs, that would be great. But again, I think there's going to be worry about the public perception of trying to use organs from animals. How are they going to behave? What sort of diseases may be transmitted? So there's also that element of it as well. But if I could take a skin cell from you and differentiate it to a stem cell and use those cells to then repopulate, scaffold, and create an organ to your genetics. So essentially, ready for you if when you might need it. I think that'd be really good.
So allographic transplants the way forward. Yeah, certainly. Okay. One final question for me. Prior to this lecture, we had a brief chat. I have no idea worldwide how many people are involved with this technology. Is it something that there's collaboration with, or is it still very insular, that one country keeps its technology and its advancements to itself and it's not really shared?
Yes, no. I mean, certainly, we've presented this work at different congresses around the world, including Hong Kong and Europe as well. And the technology is there to be used, and certainly we've got a lot of interest from various other collaborators across Europe and Asia. And I think the importance of this technology, I think, is also perhaps in low volume centers that are not doing as many of these complex transplants. So I think that's probably where the greatest value of this technology might be, to give the surgical team and the healthcare team the confidence to approach these cases. I think that's perhaps where the greatest value may lie.
Wonderful. Okay. Are there some questions from the floor?
There's one here actually. Could you, I'm a non-specialist, I'm not a medical person. Could you just explain to me what OMAR scanning is? It's a term I've not heard before.
OMAR scanning?
OMAR scan, you mentioned it earlier on.
Can't remember that. OMAR scanning? I don't think I mentioned that today.
Okay, there's another question then. You mentioned that there was a loss of adult kidneys because of the size issue. Is that something that you see 3D printing and scanning mitigating?
Exactly. Yeah.
It's obviously clearly really important.
Yeah, absolutely. So if we can try and think about ways in which we can avoid that discard by perhaps using 3D printing to try and predict whether this would work or not work, I think that may help to try and reduce that burden. Certainly for living donor transplantation. Deceased donor, where you don't quite know when a kidney is going to come, and it all usually happens fairly quickly. That might be more difficult to print because then you'd have to get scans from the donor hospital and then 3D print. And so at the moment, we're using it just for planned living donor transplantation. I think the next step will be to try and see if we can use the technology for deceased donor transplantation, which would help with that area of discard. So it's all about trying to plan so we can reduce that that situation where we have to discard an organ because of size, mismatch ratio from the donor to the recipient. Perhaps more so for liver transplantation, actually. Anyways.
And we have some questions via Zoom, which Evan Dawson, our CEO, will relay back to you.
Yeah, sure.
Yes, we have several. The first is from our own Professor Afzal Ansari, chair of the committee, of course. And he says, congratulations to Pankaj for the award and delivering an excellent lecture. My question is, what next? Any other applications? Any comments on how Christian Barnard would have used 3D printing for heart transplantation?
Well, Christian Barnard would have used it, yeah. It's interesting because I was having a conversation with David Cooper, who knew Christian Barnard quite well, and he was saying that when Barnard did the first heart transplant, he was actually petrified as the whole world was watching him, and for the first time in human history, the human chest was open without a heart beating. I don't think Christian Barnard had much time to think about 3D printing, really. I think he just wanted to get on with it and put the new heart in. What next? I think, as I said, I think the next thing really is to try and improve the process of image segmentation and to try and get that more accurate, and to try and reduce the number of hours it takes for that process using machine learning. And of course, the real big jump would be in trying to actually, as I say, create human tissue, functional human tissue, that we can then transplant into patients, based on their own genetics. So organ regeneration, I think, is the next big thing, and bioprinting. I think that would be the next big thing, really.
Okay, thank you very much. The next question is from our former president, Dr. Alan Hodgson, and he says, would colour be useful at the 3D printing stage?
Yes, absolutely. I mean, all our models at the moment are obviously in a uniform sort of colour, but there are companies out there that do print. You can print blood vessels in, if it's a vein, you can print it in blue. If it's an artery, you can print it in red. People I know have printed tumours, for example, in different colours, so from surrounding tissue. So that gives a good visual representation, if you like, of the different types of tissues within a particular area. So yeah, we can do that. Yeah.
The next question is from, if you'll forgive the pronunciation, Wojciech Simis, and he says, could you use this for emergency transplants as well, for assessment of deceased donor kidneys suitability for the specific child?
So that's a great question. So as I was saying earlier, at the moment, we're just using it for living donor transplantation, where we know that a transplant may happen in a few weeks' time. So we've got time to use the technology, if you like, because as I say, it takes time to image segment, it takes time for the model to print. But if we can use it for deceased donor transplantation, which is a much more of an emergency situation, I think that would be, again, a great step forward. It would require a printer that could be on site. It would require us to get the images from the donor hospital and then process that through straight away. So that would be an interesting clinical workflow stream to create, actually. But yeah, as I say, at the moment, we're just restricting it for planned elective work.
Thank you. The next question is from former trustee Avijit Datta, Dr. Datta. And he says, thank you for an interesting talk. He has two questions. First is there any shortening of the operating time as a result of this work? And the second is, what about using virtual reality and or holography instead? What are the relative benefits and demerits?
So the second part of that question about VR. So yes, we have looked at VR. I didn't have time to go into it, but we did look at some VR aspects. I mean, the thing about transplantation really is that we're actually placing one organ inside, if you like, a compartment. And I think in terms of tactile simulation of that process, gives the surgeon more information, really, and it gives you depth perception. Regarding operative times, we've looked at a couple of those aspects in some of our cases, and it has reduced, as I say, the time that the child is on the anaesthetic table. Because, as I said, if we prior to this, we were opening up the child first, exploring, that takes time. But if we have a model beforehand, it has actually reduced that part of the process. Not significantly, but it has. Yeah.
2 more questions, I think. This is from Holly Morganti, and she says, although 3D printing will allow planning prior to surgery to prevent discard of organs, is there still not a fundamental issue for children receiving organs from adult donors involving size differences? Is this where bioprinting would come in?
Yes, I mean, yeah, I mean, I'm not quite sure I understand fully the question, but as I said, we try and put in adult organs into children, and you know, we can put smaller kidneys into children as well. But you know, those kidneys have a high risk of thrombosing or clotting off, and in fact, we've had a couple of cases like that you know, that have happened. And of course, with the smaller kidneys, they are more susceptible to something called hyperfiltration injury as well, which can damage the actual structure of the kidney. So we tend to put adult organs into children. But having said that, the adult organ requires an adult blood pressure to drive its physiology as well. So there is that to think about. And it's amazing when you take the clamps off and the adult kidney perfuses with blood, the child's blood pressure just drops. And then the anaesthetic team now have a difficult job of trying to maintain organ flow into that. It's like a shunt, essentially. So yeah, there are you know, complexities on both sides. But you know, as I said, if we can 3D print, bioprint a kidney based on the child's genetics into a scaffold and implant that would be fantastic. And they've done that for things like the trachea before. Which is of course a much simpler organ than the human kidney.
The last question is from Rex, but I'm not sure whether it crosses the same territory. It just says, will there come a point where you can 3D print human cells?
Yeah, I mean, so as I say, you know, the cells is, I mean, the cell is a cell, but I think what the question is, can you put all those cells together in a sort of an additive layer, if you like, in terms of bioprinting? Yes, we can, and that's happening. You know, around the world.
Right, marvellous, thank you all. On that note, it's my great pleasure, Jenna, to present you with your Combined Royal Colleges Medal certificate. Wonderful work, and thank you very much for showing us tonight your endeavours.
Thank you. Thank you very much. Thank you.
There's one final thing that I have to say, and that's to thank all the relevant RPS staff for tonight's event, and that goes for Joe McDonald, Awards Manager, and various other members within the RPS team that tirelessly donate their valuable time and efforts to make things work. Michael Pritchard, the names are endless, basically. The Awards Committee, there's so many different people. Certainly, yeah, Matt tonight, looking after the IT infrastructure. I could go on. I'm afraid I don't know all the names. I'm sure I've missed plenty off. You are thought of, and to say the least, we couldn't work without you. Thank you very much for your tireless efforts. It's very much appreciated. And so all the people at home watching on Zoom, have a very good evening. And as we're approaching rapidly the period of Christmas and festivities, I hope you have a peaceful one. And we look forward to seeing you, hopefully in person next year, if a certain virus allows us. Thank you all. Good night.